Very good afternoon to everybody, and thank you for being here with us today. The mental health and disorders by the use of substance in comorbidity in Hispanic communities. If you want to listen in English, go to the tab in English in the bar to hear in English, and you can mute the original audio as well, if need be. We're going to cover some important points today. Today's webinar will be recorded. It will be available on our webpage and social media. All participants will be muted. You can raise your hand, as it were, if you're going to speak, so that we can give you a turn to speak, if that's what you want. If not, you can just write directly into the chat. Please make sure that you are muted so that you may be able to listen to today's presentation. If you have technical issues, send a message to the organization through the chat. If you have any questions, please use the question and answer tab or through the chat. We will provide a copy in PDF format through the chat. And we'll have a copy of today's presentation so you can download it on our webpage. You can find it under today's names, and it will be broadcast in our YouTube channel. Please fill out our evaluation at the end. It will help us know about your opinions and what you think about this webinar and what other themes and training you would like to have. We will share a link of the evaluation through the chat, and at the end of the presentation, you may scan the QR code to do so. Our mission is to promote sustainability and support sustainability in the equity of behavioral health through the promotion and prevention, intervention, and many different ways to recovery and support made for the community, culturally fundamented and centered on people of diverse communities and Hispanic communities. We will provide technical assistance and to promote the behavioral health workforce throughout Latin communities. I will give the mic to Hector Colon, Dr. Hector Colon, so he introduces himself. Thank you for being here with us, doctor. The mic is yours. Thank you. Thank you for the opportunity and the invitation. My name is Hector Colon Rivera. I'm a psychiatrist for teenagers. I'm general psychiatry. I'm a PAM. I'm from Vieques, Puerto Rico, and I live in Philadelphia currently. And I'm a medical director of a nonprofit in Philadelphia, and we have several departments like mental health, foster homes, housing, and drugs and alcohol. So today's objective is to understand the prevalence of comorbidity in the mental health disorders and in the use of substances in Hispanic communities. We will examine cultural factors and systemic factors that influence the risk factors and protections and safety. We will identify access barriers or obstacles to the attention and intervention, efficient interventions, and we will analyze strategies to promote the cultural attention that should be competent and have community support. We have worked on many different settings. We have educational settings like outpatient, inpatient as well, and rehabilitation and recovery. We will talk about different strategies for different treatments. So to start, what is the definition of comorbidity? It's the co-occurrence of two or more disorders. And those who see patients, we know that patients present different symptoms, whether there's psychosomatic or not. And many times, 90% of the patients don't only have a disorder, they have different disorders or medical comorbidities, whether it's high blood pressure, diabetes, and these comorbidities or concurrencies are very important. If you're going to take away something from this webinar, is that we have to try to treat disorders at the same time, not separate them or compartmentalize them. Like other states are different from Pennsylvania and have different pathways for their budget. So you have to provide different treatment or treatment in different environments, even though we're dealing with both disorders or more than one disorder at a time. The concurrency is to have two or more disorders, whether they're mental health or the use of substances. There might be physical issues or physical health issues, and these might complicate treatment, the quality of life, and the cost of medical attention. And of course, every patient, depending on the complexity, the severity, the gravity of their disorder, well, most health care plans have to be patient specific, and they need more treatment or more people dealing with this treatment. It becomes more complicated. But the main thing is to treat disorders simultaneously. In the Hispanic communities, and as I see in the chat, not everybody is Hispanic here, but I assume most of you listening are indeed Hispanic or work with Hispanics. And I know that the prevalence in the Hispanic communities since 2020 and early 2020s, 20% of adult Hispanics report some mental health during the year. And this continues to be current in 2025. We've seen an increase after the pandemic, like these incidences and prevalences have increased after that, and as well as in other communities too. And some studies point out that certain figures or statistics are low because people don't seek treatment. So they might be much higher than they have been identified, whether it's due to stigma, whether it's due to access or lack of access, whether it's a language barrier, a cultural barrier, whether treatment is culturally structured, or whether the medical community is somewhat limited, especially if they don't have health insurance or documents, papers. It makes it more complicated. A lot of treatments, places that offer treatments don't accept some health plans like Medicaid and Medicare's, and it's very complicated to seek treatment that would treat mental health through these type of health plans. And I see that you all come from different states and different rules in different rates. There's Colorado, Delaware, California, Puerto Rico, and I'm going to try to mention some of these states so that you see the difference. About 7% of Hispanic adults reported substance use disorder in the last year. We're talking about 20% almost of mental health, without including substance use, and 7% with substance use. Most substance use disorders have a mental health precedent that before the substance use presents. 60% of people with substance use disorders used to have a mental health disorder, whether it was diagnosed or not. So it is very probable that most of these patients, 7 out of 10, have a comorbidity. Alcohol continues to be the most consumed or used substance, although we are also worried and concerned about opioids and amphetamines in certain regions, especially in the cities, urban areas. We see a lot of methamphetamine, San Diego, San Francisco. We see this. In California, there has been an increase in Philadelphia of substance use reported, and it's been mixed up. The Hispanic communities are using more fentanyl, but the connection with the psilocybin and the tranq in these communities. The co-occurrence or comorbidity are people with a mental health disorder that have a higher probability of presenting a substance use disorder and vice versa. The most important thing is early detection and integral attention are essential to reduce the risk. And it's most substance or mental health disorders are diagnosed in a primary care scenario. It's very important that those that have their primary physician, that the primary health physician ask the right questions so that they can or transfer that patient on to a specialist. A lot of patients that deal with drugs and mental health, well, they will have a mental health disorder that is primary or main, and that may turn into a substance use disorder. And there's several reasons for this. There are the genetic vulnerabilities, a predisposition, whether it's through family, relatives, or mental. That's when we're talking about the psychosocial context. These increase the risks to addiction. There are two drugs that are used. One is illegal, one is legal. The legal one is alcohol, and it has a huge genetic component. But the drug that has the most genetic component is cocaine. So those who have cocaine use in their family history and they start experimenting with cocaine, they are at a higher risk, 4 times higher risk to be addicted to that drug over other drugs. So cocaine has a huge genetic factor. After that is alcohol. Usually in Hispanics, we see more use of alcohol because it's very accessible. And in South American countries, and like Puerto Rico, people start drinking a lot earlier, legally at 18, in Puerto Rico, for example. And in this context, in this psychosocial context, family members drink at home, alcohol is accessible, people celebrate with consuming alcohol. So there's a chronic stress in the society. Some call it peer pressure because you see and imitate those around you. And that puts that patient at a higher risk to consume more. The starting age also has a lot to do with this. Statistics say that if you use some sort of substance early on, and has been done, these studies have been conducted with tobacco and nicotine. If you use this before 14 years of age, when you're already in puberty and the brain has certain plasticity occurring in it, the brain continues to develop plasticity up until 21, 23 years old, depending on the sex or gender of the person. But yes, it continues developing. So those that before 14 years of age are approaching at the halfway point of teenagedom are at a higher risk if they start before 14 years old. And they have a higher risk of developing a substance abuse or substance use disorder in the future. The tendencies of mental health and substance use in Hispanic communities and culture varies year to year. The substance use, whether it's in or out, whether it's in a fad, especially in adolescence. As a psychiatric specialist in adolescence, I start talking about this at 10 years. Most states don't have a minimum of age to see a substance use disorder, but they do have a minimum age for mental health disorders in seeking consent from their parents and for treatment and their healthcare providers or whether they're guardians. In Pennsylvania, it's 14 years of age, the minimum, to seek treatment for mental health disorders, but there's no limit for substance use disorders. The next slide is a chart that says more or less how the population in the US is changing. And this is due to, we think that in 2060, for every 3 people, 1 will be of Hispanic ancestry, especially in places like Florida, Texas, California, Pennsylvania. Cities like Philadelphia have almost 16%, 20% Hispanic population, but only 3% or 4% of those who are getting treatment in healthcare are from Hispanic ancestry. That's very important to keep in mind, especially with the changes that are happening at the White House level right now and the changes to health in general with different new secretaries and public officials. A lot of mental health clinics have closed in many states, whether it's due to budget cuts or simply because they don't have the resources or the staff to work in these areas. However, technology helps a lot, but it's not enough because there are other federal rules that don't allow prescriptions or to see patients if you're remotely, if you will, if you're in another state physically. The thing about Hispanic communities is not just substance use, but also general health. We see a lot of probabilities in Hispanic having fatalities for diabetes, heart issues, diet, stress, having more than one job, the quality of life, lack of seeking physicians' help or treatment, specifically males, due to male chauvinism or the type of work they have. They they don't go to the doctor as often, or they wait too long, and they wait till the problem is more developed. They already had a stroke, or they had a heart attack. Almost 20% of Latino adolescents have reported suicidal ideations, and 1 in 10 have reported attempting suicide. And this is mixed with, you can see this in social media a lot. Even though we're talking about suicidal ideations, suicides have diminished or decreased in recent years, maybe because of marketing or maybe the new statistics, the new national statistics, and hotlines are available and maybe they are using it, and the 988 or the different available chats that are at a national level are available to callers, and every county and city has their own help to offer, which is really interesting. A lot of the social media resources are trying to identify some type of vocabulary or movement, gestures to identify those suicidal ideations. But we need to do a lot more, especially with AI. We could maybe have a better reach in relation to this. The rate of alcohol consumption in Hispanics is really high. Among Hispanics and those that, whether they migrate or move or seek shelter and refuge, are refugees and don't follow their traditions, their language, they're at a higher risk of having a disorder. And of course, oh, thank you. If I'm a Puerto Rican, go to the US and I leave my Puerto Rican traditions behind and I don't no longer speak Spanish, I don't talk to my mom who's still in Vieques, my risk for drug use is a lot higher than a brother that I may have that had moved to the United States and keeps those links with the culture, with the family relations and the family culture, family centered culture. They have more protection, more safety, and maybe I didn't choose that kind of traditions. Some things like HIV and Hep C have increased in our population. Every 6 HIV positive Hispanics recognize, acknowledge that they live with a substance use disorder. Hispanics had the highest rate in comparison to other ethnic Latin groups that have been evaluated. And why? I don't know if the culturalization or the assimilation into the US is a factor, or maybe they start earlier than in other Hispanic communities or Hispanic countries. We see this is a SAMHSA data sheet or info that tells us in the past year how many people 12 years or older used drugs and what disorder they had. 8.9 million Hispanics. Alcohol is the most prevalent at 11%. Any other drug follows. That's a vague, open question in general, but mostly by marijuana follows and then painkillers. And that's about pills, oxycodone, hydrocodone, and so forth. Very few use heroin these days. That 0.2 percentage we also see in kids and adolescents. The plateau doesn't change. Heroin has never been in among teenagers. We see more vaping use, more marijuana use, more pill use, consumption. Especially among females, we see an increase of methamphetamine use as opposed to males. The males sometimes combine cocaine with alcohol to do a upper kind of thing, which complicates the medical situation a lot because it makes the alcohol last longer in the body and become more toxic within the body. So if you're using cocaine and alcohol together, it turns into a different molecule. And that molecule stays in your body for longer amount of time, and having an effect on the heart, on the liver, obviously. And it's very important that this combination can be very lethal. So methamphetamine, depending on how you use it, there's some other risks. It can be injected, smoked, inhaled, or snorted. If you inject it, you're 20 times more likely to suffer psychosis or hallucinations. And I have had patients that have only used once within a group, and they haven't left or come out of that bad trip, and their brain is affected so much that they have a physical disability. They can't perform their physical skills like they did before. So it's very interesting that using one day can change your life forever. Can change your life forever. Even though you don't have a disorder, just experimenting might cause this. This data from 2019, we can see that 15%, approximately 17% Hispanics of 12 years of or older reported having consumed some illegal substance. This use doesn't have a disorder per se still. We call it a disorder when somebody has been using for an extended period of time. If we follow the guidelines from the DSM-5 or the DSM-5, it would be 12 months or longer. and it affects functionality, whether in school, at work, in the family. And those 9 factors that you see, if you have 2 or 3 or more, then you qualify for a disorder diagnosis. And we have all kinds of substances. We're not talking about a disorder here, we're talking about use. 15 to 17 approximately percent have used some illicit drug, whether marijuana, opioids, alcohol, plus drugs. In comparison, the prevalence of illegal drug use in the general population of the USA is a little bit higher. You know, traditions, culture, our culture kind of protects us a little. It has a certain protective or safe factor, but that doesn't protect us 100%. And depending on how you use it and how long you use it and how you use it and what you use, the disorder might be there. And before they're 14 years old, they're a higher risk to develop a disorder. When we talk about marijuana, which is one of the 2 most used substances after alcohol, this is the one that is illegal and it's most used of the illicit drugs. And if you work in substance disorders, you can pretty much count that your patients are using marijuana, whether it's prescribed or not. It's a fad to have prescriptions, but they still continue buying in the street or through the dealer and not at a dispensary. Maybe during the Q&A, you can ask questions, but that's what we're seeing. Hopefully that medical license would protect us from psychosis and other things. But marijuana is always talked about like, oh, it's not a drug, it's natural. And that's the path a lot of patients take and suffer of a manic process, or they have psychosis, or they combine it with other things. But the rate is about 13% in Hispanic population who has consumed in the last year. And not everybody that smokes marijuana has a disorder. A lot of patients smoke it as prescribed for health conditions or medical conditions, indications that have been recommended. In Pennsylvania, we have more than 13 conditions that are recommended, including opioid disorders. It's very rare that there is a disorder with opioids and marijuana, but some states like Pennsylvania can see this. This percentage is very similar to other groups. We talked about it in the other slide. There's a different, there's 15 to 17% among Hispanics in the use of substance, but the 13% of illegal marijuana use among the population, Hispanic population, has not really varied much in recent years. The use of opioids and other drugs, opioids as a prescription drug, has increased in recent years, and we have seen the charts, the curves. We start with heroin, or we start with painkillers, then they go into heroin, and then into fentanyl, then psilocybin, and we see how those waves, there are 3-4 waves since 1990s, and when Purdue Pharmacy and Johnson was normalizing the use of opioids. And so we're 1 to 2% of the Hispanic population reports illegal opioid use with prescription opioid or heroin, or they've used heroin, and maybe they are not using right away, but maybe they're going through a crisis or something, and they have a reincidence or a relapse. Oxycodone and hydrocodone and morphine and methadone, people have them at the home and they use them later. Or the teenagers has them and they share it with friends, or the adolescent sees it And when they go through a crisis or a problem, or because they're going a lot of pain because of too much football use, then they start using it. And that's when the problem starts, because usually the CDC doesn't recommend the use of oxycodone and hydrocodone according to the 2016 guidelines. And they promote other NSAID medications, acetaminophen and other things. But the problem is that they start using pills and nobody's prescribing them. So they move on to fentanyl, which is the cheapest thing in the street. And that's when the problem starts. And yes, there's a lot of patients, like my friend Martha says that they don't normalize the marijuana or alcohol use, or normalize alcohol and marijuana, and they recognize it as a normal thing. Alcohol is difficult because it's everywhere and it's accessible. Marijuana has also become a fad because it's natural. It comes from a plant, but a lot of people know that cocaine and opioids also come from plants. There are a lot of very important different in the percentages of people that use these, Hispanics that use these substances. And Hispanics are not a heterogeneous group. You know, being a Puerto Rican is not the same as being from El Salvador or being from Argentina or from other countries. Ecuador, for example. Most of my patients are Puerto Rican, but I see a lot of patients that come from other countries.
And yes, the use is different. The way that people use it is different. Puerto Ricans present a higher rate of illicit drug use, and that's the data that we're using. There's not many new studies. It's been since 2012, but it's still pertinent because it's what we're still seeing. Versus South Americans who have a lower rate, 2% versus 17%. Puerto Ricans also have a higher rate of marijuana use amongst Cubans and South Americans. We see less of a rate. We do see a higher rate in South America of cocaine, where it was probably easier to access in South America than in the United States, maybe in more pure or more price accessible, whereas Cubans have the lowest rate of cocaine use. Very interesting how we see here how almost all Hispanics who received treatment or did not receive treatment thought at the end that they did not need it, which is very interesting. So we do see how the patients who did not receive treatment felt that they didn't need the treatment. And in some surveys, we have identified this as well. Usually, Hispanic patients who suffer from a substance abuse disorder prefer to seek out help from family, neighbors, anything before seeking out treatment. I don't know if you've seen, especially amongst men, they seek out treatment when the condition has impacted other types of organs, or they had to go to the emergency room because of a heart attack or pancreatitis or liver issues. And that is the indirect way in which the doctor or the family discovered that the patient was drinking too much or using some kind of drug. Unlike women who usually seek help when they feel that something is different. There is a lot of denial and a lot of pre-contemplation in terms of the states of change amongst Hispanic patients before they accept treatment or a referral. They minimize the use of alcohol a lot and the use of tobacco as well, oftentimes in the first visits. This is an example of how many patients The first one is patients who did not receive treatment 12 years and older, who have a alcohol disorder or illicit substance abuse disorder. We see how amongst 12 to 18, only 5% receive treatment, any kind of treatment. We're not even talking about it receiving the treatment they actually need. We're not saying that if they have opioid use, that they're doing methadone or anything like that. We're saying they saw someone. They saw someone in the emergency room or their primary doctor referred them. We see a little bit how it goes up around the 18 years of age, especially those who have a severe disorder. A little less amongst those in whom the disorder is more moderate or not very serious, but we do see it more in those who have severe disorders. And between 12 and 16 years old, or 18 years old, we see how they receive more treatment because of the primary diagnosis than the comorbidity they might have regarding the use of substances. So we can see how the graph on the right identifies almost a 30% that receive treatment for depression disorder versus 5% that had received treatment for drug use. It's easy to explain, I would say. Oftentimes, the primary or the pediatrician identifies a depression. They want their PHQ-2, PHQ-9, which are scales, surveys, which have various questions, and this gives them a number and a metric. And depending if they're older than 10, more than 20 is severe, those metrics are pretty common and done in the primary health care, and they identify it and they treat it. Substance abuse is different. Oftentimes we don't identify it on time. We don't do so many studies. We don't do urine tests. I'm not saying that would be the recommended approach, but it is oftentimes identified later. Oftentimes parents don't know that the child is doing drugs until something happens regarding the legal arena or some sort of complaint in the school, or they lower their grades drastically, or one day they get home super high and then they can't deny the use. It's very interesting how almost 90% do not receive any treatment for substance abuse. And a lot of attention, what we're talking about is mental health and health in general. Here we have some criteria. We know that we need more treatment or more discernment. We see how we have not seen changes in the past year. This is an example. This is we call the National Survey on Drug Use and Health, NSDUS. They do this every 3 to 4 years since 2021. And from 2018 to 2021, there was no change. However, the conditions have increased. We see how the adults that receive treatment or orientation in the last 12 months, it was worse than in the last survey. Same with kids 12 to 17 with depressive episodes. The only thing that we saw an improvement on was in deaths by suicide, not attempts, but deaths by suicide. So that rate was reduced. It could be because of public health and the money and the advances they've done in terms of suicide and life. Those are good news. In terms of treatment for depression and others, we have not seen improvement. It's actually worse. There are a lot of behavioral things that don't help. We see a lot of deficiencies in the amount of mental health providers we have available. There is a lot of information regarding primary health care that is relevant, and I congratulate our primary health care workers because oftentimes they are the ones who refer their patients to mental health. A lot of our Hispanic patients present with a physical problem before they say that it could be depression, a lot of somatic issues, headaches, neck pain, tired. A lot of professionals with burnt out. They'll say that they feel burnt out, but they won't say they're depressed, and we identify it as such. 50% of the visits to 70% of visits to primary care are related to behavioral health needs. And also we see this in emergency rooms. Oftentimes they'll show up with palpitations or chest pain, and it's really a panic attack or too much anxiety. There are mental health disorders that we see 50% 50% is treated in the PCP, and 1 in 5 is affected by behavioral health. Imagine if each patient, if 20% of the patients that you see have, their main complaint is because of a mental health problem. Some of them don't have the tools to deal with it, and sometimes they don't get the help they need. Between 10 and 30% of patients suffer from depression. And oftentimes the doctors it's not detected in the primary care. Psychotherapies are not always available in that environment, and they have to be referred due to the gravity of the depression. And sometimes depression is detected, but we don't know at what level, and medications and are given at low doses. So I recommend to always be present and identify and clarify what type of depression, what type of mental health disorder. Evaluate the goals and motivations of the patient. And regarding to the patient, we have to identify if they're in contemplation, pre-contemplation. And these are cycles that repeat themselves with many patients, but we have to identify in which phase they are to be able to refer them to the type of treatment they need. PHQ and all those are very simple tests. It's just asking them questions from 0 to 4. How do you feel the last 2 weeks? 4 being every day, you feel depressed, or 0 being none of those 14 days. They're very easy to do. Takes about 30 seconds per question. Probably just a few minutes to complete it. The evaluation has to deal with functioning. If the function is failing or just reduced, then we have to, that's important. And that function might change as you see the patient and when you see them in the different appointments, you have to measure that. Biological causes might always be present, so we have to eliminate any kind of biology, be it thyroid, anemia. These symptoms and disorders can have similar symptoms like tiredness, lack of concentration. and depression. And suicidal ideation, we always have to ask about that, whether there's comorbidity or not. We have to ask about suicidal ideation. And obviously make sure that if the patient starts treatment, that he is applying the treatment, be therapy or medications. Many of the medications we cannot measure levels. And if we have a comorbidity with depression and substance abuse disorder, it's important that we treat both. But sometimes it's easier to keep a maintenance of the opioid use. We can change the levels, do urine, medications, and make sure if the patient, the PDMP, the website, we monitor them. The recipe that the patient actually makes sure they actually picked up the prescription, versus with depression and those kinds of medications, we can't monitor in that same way. Prevention, which we often don't talk about, and evaluation treatment. Prevention is very important. We have the example of alcohol abuse disorder, since it's so prevalent in the United States, between 8 to 10%. So we have to ask those kinds of questions. There's the case, which is very simple. You ask 4 questions, and simply if one is positive, then that's it. The patient has some kind of, requires some kind of intervention. Maybe not treatment with medications and therapy, but definitely an intervention for that kind, for the level of alcohol use. The use of alcohol also presents with a lot of anxiety and a lot of depression. And usually we see a simultaneous of this up to 20%. Every 1 of 5 patients has some sort of anxiety or depression when they are consuming alcohol. And the co-occurrence of alcohol use with other disorders makes the diagnosis worse and increases the probability. So we have to follow up on them. And there are medications that help us, that are approved by the FDA to treat a comorbidity, an anxiety or a disorder or a depression disorder with alcohol abuse. And there are medications that help for both of these. The alcohol abuse disorder in Hispanics, it's important to do good screening and identify the disorder. The intervention is not that good based on our data, 56% or less. But the prescription and treatment, that monitoring, we have a lot of work to do in that area. Only 5% of Hispanic patients who are identified with an alcohol abuse disorder are treated with those medications that have been approved for this. There are many barriers for this type of implementation. For the use of medications or therapies, there are barriers that are on a systematic level. Government policies, how does the provider feel about prescribing this kind of medication or therapy? Also, the patient has a lot of problems identifying that this medication is good or bad. There's a lot of fear, a lot of uncertainty and ambivalence. There's also cultural factors and social factors, not just the system or the provider. There's also cultural and social aspects. We have familismo, which is strong familiar orientation, which has its positive and negative aspects. The positive is that it provides social support, but also that the family can create a culture of silence and negation or ambivalence regarding the patient's desire to access treatment. There's a barrier of language, and we speak both languages in my practice, but there's a lot of clinics that don't have that language access. and translators and interpreters need to be used, and it's a little bit more complicated to do therapy for their patients. A lot of states need licenses if you're prescribing medication for substance abuse disorder. So sometimes it's complicated because since it's mandated that the patient receive a certain number of hours to be able to receive treatment, and we don't have the resources because the staff is not available, or we don't have enough staff for so many people who need people to speak their language, and sometimes it gets complicated. And so it's complicated, and we have to look for outside resources. And there's the stress of other requirements and bureaucracies and all that type of thing. There's acculturation stress as well. There's patients that are Puerto Rican or Hispanic, and they have just moved and oftentimes without any help or support system, no school for the kids, without preparation, without home. And it's very complicated because then it's not just the mental health disorder or the substance abuse disorder, but also the social environment, which creates a lot of stress and pushes that patient to maybe use or medicate themselves with alcohol or the different types of drugs. And so, interestingly, when we talk about acculturation, I have a lot of patients in the legal system. And this acculturation is present in the legal system when they're in prison. Many patients don't have substance abuse issues or in general, but oftentimes they start using drugs when they are in prison. And you might say, how do they find drugs in prison? Well, there's many ways, and many ways to access different types of drugs. And oftentimes they start using drugs in jail, prison, and then come out addicted or with a substance abuse disorder. And there's a gap of time in which the patient starts using again or starts using things on the street, be it fentanyl or anything like that. So adapting to that culture of being in prison, then adapting when they get out of prison, these are examples of acculturation that we see a lot about and we don't talk about. And many patients that we see here in Puerto Rico, as we say, they move because of factors that don't have to do, like hurricanes, politics, losing their job.
Or for positive things to looking improvement or better access to health plans or access to doctors who are specialists. A big example that I use is autism or problem with children with disabilities that are not on the island, and there are more services here, and the lines are not so long. They move without orientation or guides, and a lot of parents fall into drug use as well. And we see that with the financial factors, they have limited resources. Even though the ones that have a little bit more resources, they don't ready themselves, and the kids have more problems because they don't speak English, and the stress increases. There are barriers to attention. There's stigma and disinformation that we see in our communities, beliefs that whether to seek for help is a sign of weakness, a lack of providers that don't see our culture. They don't only speak the language, but they also understand the culture. Our wishful thinking is that both of them would go hand in hand, and then the patient would feel that they're not just speaking my language, but they understand me culturally as well. Systemic problems, we see racism continuing to be a problem along with discrimination. We see against Hispanics, we see a lot in the news. We see it currently right now, a lot of fear to the legal consequences. I have a lot of patients that are immigrants and they don't want to come to the clinics. And we see them remotely or because they don't have their papers or documents, or they're fearful that ICE or migration authorities would take them away because they've seen this happening in their communities. And we see it continuing to happen. The concern of migratory status is very first in the forefront. There are other influences in if we have under a lot of stress, even though we are receiving treatment, we have more urgency to use. We have more desire to self-medicate. These desires are higher. It affects the mood. It has an effect on the use of drugs. And the comorbidities often remain without diagnosis or treatment. A lot of times we don't diagnose the use of substances or substance use disorder, and then if we don't see it, then prevention is not going to happen. There's more probability or intensification for comorbidity disorders. For example, if they're just going through depression, in a lot of states, they don't allow a dual diagnosis or dual units, as they say. The clinics are not treating both diagnoses simultaneously, and then you have to refer the patient, and they are under two different systems. Transportation is made harder, the timing is made harder. It conflicts with work schedules, and things are complicated. The risks in the patient for relapse and medical complications has an effect on the general Hispanic population because it affects the medical treatment. And in a lot of societies, we see a lot of negative outcomes for Hispanics and their families. So we focus on an integrated treatment so that we can treat both. A lot of my colleagues practice holistic treatments, and that means treating mental health disorder along with substance use disorders, considering physical health and cultural factors and social determinants of health, which became kind of like a very popular phrase after COVID-19, although it's always been there. But after that, people assigned it more importance because it came to the surface and we saw it in the communities, affecting our communities. It was obvious. It was more obvious that it was happening. As far as the models go, there are a lot of integrated models. They also, some include a primary health treatment along with mental health treatment. There's some models that provide home care. There are other models that have a presence in the community with mobile units, providing methadone in those communities, even though there's not a methadone clinic. They're part of a clinic and they go to the patient. They provide the access to the patient. And it also includes accessibility in terms of language or language accessibility. A lot of providers right now, not only clinical providers, but healthcare plan providers have accessibility or have access or provide access to the patient of a DPT. And that's a right of the patient that that clinic or that health plan that they have provide an interpreter. And the interpreter might be related, a family member. It could be a culturally accepted member of society by the patient. A lot of Arab patients For example, even though other countries speak Arab, they rather have somebody from their country to come and interpret for them. And having these helps or community help in mind, there's a certain reach in the community. I work with schools a lot. A lot of my colleagues work with churches. There's very important to have events that we can educate the patients through different generations of patients. And this community helps. It doesn't mean that everybody will learn the same way. Some patients go to church, other patients go to the barber shop, or they go to the square, town square, or and then you have to have activities in different areas so that you can reach different areas of the community, especially adolescents who are not going to go to church probably, or they stop going to church, or they go some days. We have to get access to them either through the schools, through social media. It's very important to have a community reach or outreach, and that they know what the resources are available in their communities. Training providers is very important, very, very important. I don't know if you know any of the models abroad, but there's one called ECHO, SCHO. It's the ECHO model. You have a professional or somebody who knows about the topic, and they conduct webinars like this, and they train the trainers, if you will. They have a doctor that is well versed in addiction, and he trains all the primary care physicians, and those primary care physicians train other primary care physicians or nurses or caregivers. And so everybody has a base. The ECHO program is used to promote this base and to increase the knowledge of this base. And then that's the way you train and provide skills and continuing ed in areas that, or in segments that don't have an expert in drug addiction, especially in rural areas like in Puerto Rico. There are no specialists. I'll tell you an example. In Vieques, I don't know if you know about Vieques, it's an island municipality. There are no psychiatrists there. One of the models that we could use in Vieques and has been proposed, it's to use remote psychiatry treatment and use the ECHO model to increase the primary physician's knowledge so that they can diagnose certain symptoms or identify signals of substance use disorder or mental health disorders. There are other cultural things that we see in traditional medicine, like healing, cultural beliefs are taken into account, and that way they can facilitate connection with the healthcare professional. For example, they can bring a healthcare professional to an event in Puerto Rico or an event that is related to other communities like Haitian communities and provide that education to them. We want people to be treated bilingually and maybe using Spanglish. And maybe we have to do that. Maybe we can have just an interpreter or a translator in these Hispanic communities, that more and more you see the ones that are born here and generational down the line generationally don't speak the language or don't master the language. There are a lot of therapies based on cultural models in family-centered treatment, for example, to add family members, especially when we're talking about children or adolescents. There's a lot of, it's very important that not only therapies, art therapy, music therapy are considered, not just behavioral therapy, which we refer to often, especially in children and adolescents. It's very important to include different types of therapies. There are school programs, for example, that us health professionals can go to school and provide talks and see patients and identify cases that can be referred. We have to do community outreach and campaigns like 988, which has been very successful and has been used a lot. A lot of support groups for family members were like NAMI, for example, that are support groups for the family members that are of individuals that are suffering a disorder or are going through experiencing a disorder. School and youth, a lot of talks and conferences and getting the parents involved in school meetings, to promote a good life, a good emotional life, to talk so that the family can talk about budgets, for example, how to save, how to have mentorships, how to talk about sports. This is all very important. And that needs to include the family members within the community. We have to combine resources and access so that these resources should be bilingual, really. There should be one in English, one in Spanish, and there shouldn't be two different ones. I prefer them that way. There are digital platforms. I don't know if we have AI here, but AI is being used a lot. I wouldn't recommend it yet because it's still in development, but there are a lot of resources that are using that technology to increase or improve access. You got to, pick it or take it with a grain of salt, because if it's developed enough, then you can use it. Key alliances that I would recommend are, for example, SAMHSA, although they have suffered budget cuts with the new administration, but there are still good resources for prevention and training that I recommend in Spanish, especially. There's also the alcohol disorder treatment, and they use different resources for this. There are also local organizations that we have to identify and be able to locate, especially clinics that can formalize what I call an MAU, like a contract, like a memorandum of understanding, that does indeed make it easier to refer to these clinics. So it's very important to talk to the leaders of these places so that you can fast track in some way so that the patients are attended and addressed. And this increases access to my patients and to patients in general. And I see a lot of questions in the chat. I think we should open to question and answers right now. I know there's a lot of information that I just provided. Somebody's asking, I know they asked about what medications are used for alcohol treatment. There are 3 medications that are approved by the FDA to be used with alcohol. The most used, and in my opinion, the most efficient or effective one, is naltrexone. That it can come in an injectable form, and the brand name is Divitrol, and that's every 4 weeks. It's also approved for opioids and for alcohol. For alcohol, there's also Antabuse, which is a medication that you can take, and if you drink alcohol, you get sick and suffer through withdrawals if you drink while in this medication. I mean, the symptoms can be triggered by touching sanitary wipes or perfumes. Another medication is Camproset or Campra, which is taken 3 times a day. That one, if you have a patient that doesn't like to take medication and you prescribe something that they have to take 3 times a day, then it becomes complicated. I think the easiest one, the one that is more supported by the data, is naltrexone. And that's the one that's been studied the most. And it's approved for opioid and alcohol use. It's also been used for patients with behavioral addictions, whether it's gambling, gaming, or internet addiction, or eating disorders. They've used it for this type of conditions a lot. Very good question. Any other questions? You have the QR for and the URL for the survey. It's a theme that we can talk for a very long time, and you can approach it in different ways. What Hispanic communities are going through right now. I mentioned more cases dealing with alcohol or opioids, but any of these disorders could have its own presentation within Hispanic communities. The name of my organization is APM, is Asociación de Puertorriqueños en Marcha, Puerto Ricans Associated Forward. It's a literal kind of loose translation. And I'm here at the best disposition here in Philadelphia. And it would be great if you can write me an email. I would love for you to tell me about your Hispanic or clinics dealing with Hispanics in different states, and to hear what you're doing and how we can collaborate or improve what we're doing, especially during these very hard times for our Hispanic communities. A detail that I forgot to mention, we have a new program. It's mentalhealth.org or saludmental.org. It's a psychiatric program. And I'm going to write it in the chat so you can have access to it. It's free information that you can get in Spanish. And I'm always looking for help to broaden those sources of information so that they know the culture and the language.
Know the language and are interested in education or psychoeducation for patients and families. There's not a site for members of the patients themselves, but for their family members. It would be great if you know anybody who likes to do public speaking or educate patients and family members, and this is a good resource that we are expanding instead of cutting back on. Thank you, Doctor, for this great workshop today. We currently don't have any more questions, so if anybody has questions, we still have some time left. Sylvia is asking me on the graphic, they don't improve with treatment. Can the results be reverted? It's complicated because oftentimes the data does not tell me what kind of treatment was applied, or was it directly applied depending on the severity of the disorder, or if both disorders were treated. What's interesting in that type of graph is that oftentimes it doesn't refer the patient to the professional to treat their disorder, but the patient also it depends on what state they're in contemplation or pre-contemplation. And in that period of change, it's very important to what the motivation of the patient is, and make use of motivational interviews. And many providers don't have the skills to do that kind of intervention. Very important, especially with adolescents, and if they have a serious substance abuse disorder, please refer them to a mental health professional who is knowledgeable about substance abuse disorders. Yes, it's not easy to revert the graph, but it could be reverted with the adequate resources. Well, thank you, Doctor, for your presence today and your time. we will definitely be working on this subject probably in broader terms at another time, and we will let our participants know, everyone who is here. So thank you for being with us, and we will officially end this meeting today. Thank you to everyone. Have a good afternoon.